did. And I took care of my father, who passed away with bladder cancer. And fortunately for us, we were able to keep him at home and to administer pain management medications that kept him comfortable. And I think there's a very distinct supposition that we have to make when we're looking at this and considering this is the line between pain management and keeping someone comfortable and euthanasia, suicide, and actually killing someone. And that's what that article very well describes, that there is a definition. And that's what this bill talks about, is pain management. It has absolutely nothing to do with euthanasia and suicide and killing. So I want to make that very clear and very upfront. The bill did pass in the Senate 45-0. And I think really there's only, I've also heard from, Madam Chairwoman, I've heard from other people who would like to make changes to it. I am agreeable to making changes as long as they're within the intent of hospice care and taking care of folks at the end of life. I have absolutely no problem with that. And the pharmaceutical industry came to me, and not pharmaceutical, well, pharmaceutical companies manufacturers came to me and would like to put an amendment in. And I believe they may have passed out an amendment. But the bill, just to go over it briefly, the same thing as last year. It talks about a health care caregiver being able to administer a controlled substance for relief of pain. And on page 2, it talks about the guidelines and setting up the acceptable guidelines. It describes who a health care provider is. It talks about clinical expert, disciplinary action. It includes medical doctors, RNs, and pharmacists. It describes what therapeutic purposes are. On page 3, I think that would be where we would insert. It talks about a pharmacist on line 25. If we could skip down and give a release of responsibility for the manufacturers. And that was the one amendment that we talked about. And the most important part, I think, of the bill is on page 4 on line 8, where it talks about causing or assisting in causing the suicide, euthanasia, or mercy killing of any individual. That for absolutely no reason, that's not the intent of this bill or the purposes. And it goes on to talk about regulatory boards of the different healthcare professionals and disciplinary action and how you would implement that. Section 2 on page 4 goes into talking about the ad hoc advisory committee, the creation of it, and the next page goes on that talks about the composition. There is one typographical error that in the composing the bill was brought up on page 5, line 14, where it says the committee shall consist of 15 members. It should be 19 members when you add up 5 members appointed by the governor, 6 members by the president pro tem, and 4 members by the Speaker of the House of Representatives. So that needs to be changed to 19. And of course, because this bill has laid over, and unfortunately it did get a little bit bogged down in rules, but we won't go there, will we? It talks about on line 28 the effective date. So those dates need to be changed. February 1st, 2006, and May 15th, 2006, and December 31st, 2006, to reflect the year 2007. And I believe y'all did get that amendment, proposed amendment, handed out. And if I could just address that amendment, it talks about on line 5 the pharmaceutical manufacturer, talks about what that is, and that's already taken from an existing code section that describes that.
Can you hold for just a minute?
Okay.
Does the committee members have it? It's 33.
Yes, it is.
0373. See if it. The back row doesn't have it? Jerry's any more?
I know we made enough copies. They may not.
Since we're not taking action, will you just explain the amendment and before we take action on the bill?
It's pretty brief. I can read it. It just says, and it's taken, like I said already, from an existing code section, a description of what constitutes a pharmaceutical manufacturer means an individual, corporation, partnership, or association engaged in the production, preparation, propagation, conversion, or processing of a drug or device, either directly or indirectly by extraction from substance. So it's basically saying anyone who makes a device or a drug, their liability would be limited. And on line 14, a pharmaceutical manufacturer shall be immune from civil and criminal liability for the actions or actions of a healthcare provider pursuant to the provisions of this code section. And I think it goes along with the exclusion that is given to the healthcare workers in here also.
Senator, I don't know what's the matter this morning. I seem to having trouble with addressing the upper chamber and getting that word out. For our audience, both on the web and some members that were not here during the discussion last year, could I just quickly see if I can summarize what the bill is covering, basically? I mean, one of the things that Dr. Elizabeth Kubler-Ross, who dealt with dying, said that our greatest fears are dying alone, dying in the dark, and dying in pain. It's my understanding that the purpose of this bill was to address especially the dying in pain and the fact that many physicians across our state and across this country are afraid to give pain medicine in doses that are above the normal accepted level of doses for pain medication to people who are dying, even though the amount of pain and the type of pain that they have is not being controlled by those normal doses. And in this bill was to address that and to give those doctors immunity and the pharmacists immunity for ordering drugs and pain medication above what is the accepted normal medical accepted amount of pain medication. And this amendment would then also give the manufacturer of the drugs that they order immunity also, so that somebody could not go back at the drug company.
And this is called palliative care.
Palliative care.
Yes.
Does that sort of put it in a nutshell?
That puts it in a nutshell, and if you read that article, it talks about exactly what you're talking about, the end of life, and making it so that folks can stay at home. Because if people are taken care of when they're dying in their last days, they're not going to resort to suicide or to euthanasia if they're taken care of correctly. If they're lying there comfortably, they're not going to think of some way to actually go a step further. And we have experts, physicians, nurses, hospice care, that are experts in actually providing this kind of care. And what this bill does, it protects them and allows them to be able to accomplish this. So that's why I think it came across very well in the Senate, and it came across in this committee as very compassionate care, and we're compassionate people.
And certainly cost is not our main objective. It is truly making the citizens of Georgia in the last stages of life comfortable and to letting them die with dignity. But it's my understanding that about 60% of our health care costs for Medicaid and Medicare is in perhaps the last 2 weeks of life in hospitalization costs from people having to be admitted to the hospital when they would prefer to die at home among their loved ones in their own surroundings, but are unable to get the care and the pain relief they need without being in the hospital, and even then cannot often get the pain relief they need. I think we have some questions, and we'll take questions from the committee for the senator before we have, I know we have some people that want to testify on this issue, some experts. So, Fran Millar, Representative Millar.
Yes, sir.
I think it's a great bill. You covered a couple of these amendments to the 19, and I guess you just want the year 07 instead of 06.
Yes,
Okay.
yes.
My question is, I'm trying to, other than people that are concerned about assisted suicide, which is taken care of in the bill, what are the concerns that anybody would have with this bill other than maybe addiction because of exceeding certain
Yes.
dosages?
Yes.
Is that the major
Yes.
concern that you've heard? And I just wondered,
Well,
are we addressing that, or?
Well, addiction is covered in here, and that is an issue. I forget what page that's on. Let's see. Addiction is, do y'all see it somewhere? I know it's in here. Addiction is covered. Oh, chemical dependency, page 3, line 17. Regardless of a patient's prior or current chemical dependency or addiction. And really, there hasn't been a whole lot of opposition. It's just clearly defining in the code section the delineation between that compassionate care and taking care of someone and being held harmless for doing that and assisted suicide.
Okay. That's fine. Thank you very much.
Are there other questions?
I believe you'll remember, Senator, it's good to see you again,
Yes.
that this time last year when we were going through all of this, I had just been through this experience with my father, and I'm very concerned that it go through. I'm very supportive, and I think there is a lot of misconception about the difference in palliative care and hospice care, and could you just, is there a difference, and could you explain that?
Well, actually, I think we have here that they're going to testify before the committee,
Okay.
and they're the professionals, and I'm sure they can explain it much more better than I can.
And I'm glad you brought, may I follow up? That you, someone mentioned, or Representative Millar mentioned the addiction part of that. I know that the fear of my father of getting addicted at 86 and dying, you know.
Right.
Because he was reading stories and
Right.
hearing on the news about OxyContin was
Right.
one reason why he would decide not to take it. And it was something that was very difficult to explain to him, that he didn't have to worry about that.
Well, the more we talk about it, and it's great that y'all are, and I commend y'all for televising your committee meetings, the more we educate people and the more they learn about it and see that it's okay to talk about these kind of things and to do this, that's a good thing, and you know, it really helps out.
I agree. Thank you.
And I think, the audience knows that Representative Kidd's father was one of our former governors who served this state so well, Governor Vandiver. So we appreciate that service that he did for our state. Are there any other questions from the committee? If not, Senator Underwood, thank you for doing this.
Thank you.
And I understand, a little birdie told me that we have something good to think about right now, that you have a birthday tomorrow. So happy birthday.
I don't know how good.
A day early. So, okay, thank you very
Thank you.
much.
Thank you very much.
Let's call okay, we'll just go down the list of the people that have signed up to testify. Mr. Prather, you would come forward and be sure and identify yourself, your name, and association you're with. We sort of keep the remarks, I think, with the number of people we have to about 3 minutes. I'm not going to...
I won't be that long unless you have a question.
Okay, thank you.
My name's Bill Prather. I'm a community pharmacist in Blue Ridge, Georgia, and I'm also the current president of the State Board of Pharmacy. I'm here to speak in favor of this bill. The Board of Pharmacy has reviewed it, and we are 100% in favor of it. And I would be happy to answer any questions that you had.
Are there any questions? Okay.
Yes, ma'am.
Let's see. Representative? Representative Henson.
I know that pharmacists are having difficulties with with the amount of prescriptions that can be written, especially end of life. Have you encountered any of those problems at all?
No, ma'am. In my private practice, I deal with hospice patients quite frequently. There are some stipulations in the law that give us some leeway in dealing with prescriptions for hospice patients. Just haven't had a problem with that.
One of the other things I found very interesting, a friend of mine unfortunately just lost her mother and dealt with hospice care, and apparently the rules governing the prescriptions for hospice patients are somewhat different in the sense that can be called in and then the prescription can be sent in within X amount of time to the pharmacy. Could you explain that a little?
Most of the drugs that we will be dealing with in this type of situation are what we call Schedule II narcotics. They're the most highly regulated narcotics that we have. They cannot be phoned in by a physician. They require a written prescription, which is written and signed by the physician and presented to the pharmacist. In the case of hospice care, those prescriptions can be faxed in to the pharmacy, and that fax stands as a legal copy as long as that patient is in hospice care.
Thank you very much. Are there any other questions from the committee? Thank you very much, Mr. Prather. What's our next person? Okay, our next person, Sonia Singeson. I bet I butchered it.
That's okay. My name is Sonia Sankson. I am a pharmacist, and I'm currently Vice President of Pharmacy Services for United Pharmacy. United Pharmacy is a subsidiary of UHS Pruitt Corporation. UHS Pruitt Corporation is a multifaceted healthcare company that provides skilled nursing facility, rehab services, home health, hospice, long-term care pharmacy services to about 13,000 patients over 3 states. A majority of those patients, though, and clients are here in the state of Georgia, though. Just to speak a little bit about myself, I'm not going to tell you how many years I've spent in different locations because I don't want anybody adding them up. I did spend some time in the pharmaceutical manufacturer industry, but a majority of my time has been with United Pharmacy Services. While I've been with United Pharmacy, a majority of that, even though now I'm a very administrative position, a majority of my time has been with indirect patient care, and that is doing drug regimen reviews and consultations in the skilled nursing facilities, but also in an inpatient hospice unit. Nothing can be truer in treating pain. When you talk about medicine always being an art and not a science, the management of pain, it couldn't be more true in talking about that. As you guys probably know, when these recommended dosages come about, they come about through clinical trials with the pharmaceutical manufacturers. These clinical trials are very limited in their number of people. They're limited in their variability of patients, so their fit is limited as well. When a drug actually makes it onto the market, it is, those dosages are guidelines, but certainly what might be appropriate for one patient is not appropriate for the other. And when we're treating these patients, and we have a physician who is monitoring the patient very closely, we have a nurse who is taking vital signs and pulses and everything else, and then we have a pharmacist who's very closely involved in making dosage recommendations and working with the patient, that's how these patients get the best care. It is true that tolerance to these pain medications does occur, which does require higher doses the longer the patient is on the medication. While addiction is an issue in our society, it is not an issue when someone's dying and they need their pain effectively treated. There's a stigma in our society about addiction among the patients and the healthcare providers. And anecdotally, I can speak to a patient we were trying to treat at our inpatient hospice unit who the nurses were concerned. They couldn't seem to get her pain under control. I was speaking to her personally, and she said she really didn't want to take any more, or raise the dose, because she was afraid she was going to get addicted. And that's just unfortunate that our patients have to be worried. She didn't live 10 days beyond that. And she was worried 10 days before her death that she was going to become addicted to the medication. At the same time, I was not the dispensing pharmacist, I was the consultant pharmacist. So as we were trying to increase her dose, there was some hesitancy of the dispensing pharmacist to dispense the dose because it was beyond what the package insert recommended. And I think that's unfortunate. The concern is that they'll lose their license, and I hear that phrase frequently, that I'm afraid I will lose my license because it's beyond the package insert. If we could just take that off of the pharmacists and the physicians and the healthcare providers and give them a little more comfort that they are, we are monitoring these patients, we are trying to take care of them, and we are trying to treat their pain effectively. That is the goal. That's the goal, is to provide the comfort. Obviously, this is not, it's very clear, this is not promoting assisted suicide, physician-assisted suicide, or euthanasia. I think those events come about because people are suffering and their pain is not treated, or they've had experiences with family members or loved ones who they've seen die in pain, and we don't want them to have to die that way. So thank you for your time.
Thank you very much. Representative Henson?
Thank you. When you go beyond the recommended dosage, I know with insurance companies and prescriptions, if it says you're supposed to have, 1 pill a day and your doctor wants you to take 2, the insurance company says, gee, we're only going to pay for 1. We're not going to pay for 2. Could you explain how that works with payment for medications, end-of-life, hospice care, etc., where you are greatly increasing the dosage in terms of payment, insurance reimbursement on that? I know you're probably dealing with Medicare in a lot of cases. Well, I don't know if Medicare is paying for it, but Medicaid, for example.
Well, it really, that sort of issue comes about differently with different types of medications. As far as pain medications are concerned, and all the pharmacists up here, correct me if I'm wrong, because of the way they're prescribed, it really is not as much of an issue. There are some pain medications that very specifically, and it just has to do with their half-life, it doesn't have to do with the milligram of dosage, that the insurance companies will probably, some would say they would only pay for 2 a day. But it's really not, it's not as much of an issue with this type of medication, just because the doses or the amount of tablets you can use or the amount of milligrams you could use are so varied.
Representative Graves?
Thank you, Madam Chair. If I can kind of add a little bit to that. In my pharmacy practice, I deal with 5 hospice contracts most of the time. And one thing you need to realize is that once a patient is placed in hospice, the general rule of hospice is a diagnosed 6 months or less to live. So quite honestly, the addiction portion is not really a debatable factor. You may become addicted, but if you're 6 months or less, the goal is a pain-free end of life. In regard to Representative Henson's question about reimbursement, once a patient goes into a qualified hospice program, the hospice unit that they go in pretty much accepts all the payment requirements. It comes off of the private insurance, it comes off of Medicaid or whatever it is. All the funding mechanism goes back into the hospice program. So they have in most of the hospice programs that in your situation where you have a in-house hospice program, y'all are dealing with that with your own pharmacies, contract and everything. In my particular situation, which is an outpatient retail, I contract with each one of those different hospice provider groups, and it is understood that inside that group, they're making the payments and the reimbursements to the pharmacist. They understand the need for changes in doses. I may fill a prescription on Monday that says take 1 tablet 4 times a day. And we get so many tablets, and that's going to be a 10-day supply. But 3 days later, the dosage may change. But it's all within a controlled environment with working with the physicians, with the nurses, with the unit, and the pharmacists. And they understand the dosage has changed. It is faster than that normal insurance company would pay. They would, if I sent it, they would say no. But inside the hospice unit, and for those of you that have been fortunate enough not to work with a hospice group, you cannot understand how dedicated these nurses and these groups are to go into people's home to to really get out there and make not so much just the patient feel a more comfortable end of life, but also the family members and those extended persons that have to deal with the tragedy of whatever terminal illness that patient has. So it's not really an issue on the payment side because those caregivers in the hospice programs tend to take that over.
Thank you, Representative Greggs. Thank you very much, Sonia, for coming. Thank you for your testimony. Ann Williams?
Madam Chairman and members of the committee, I'm Ann Williams, Legislative Chair of the Georgia Council on Aging. I'm an advocate for Georgia's seniors, and on behalf of the Council and older Georgians, I thank you for the opportunity to testify before you. The Council, in its advisory capacity to the state government, wishes to address Senate Bill 109. The Council has participated in discussions with providers of services for older Georgians concerning the use of pain-relieving measures for older patients. We understand that controversy can arise, particularly over the use of controlled substances of pain relief. What we know is that often people at the end of life experience significant and sometimes intractable pain. The Council supports legislation that permits healthcare providers to use their professional judgment to provide medical treatment for the therapeutic use of pain relief, so long as the generally accepted standards for pain management practices are followed. As an individual also, I testified earlier in front of this committee on this same bill, and I cited an instance of a friend of mine who had incurable lung cancer and who was in considerable pain. So I testified hoping that perhaps this past year that something could be done. When I saw her at the hospital, I told her that I'd done that, and she said, "Listen, if I could come down in my hospital bed with everything attached to me, I would come down and testify myself." As it turns out, she spent the last 3 months of her life in intractable pain. They gave her drip in her spinal cords, but they couldn't give her enough. And so she spent the last 3 months of her life with what she termed, on a scale of 1 to 10, 9 to 10 pain all the time. Of course, when my mother was in the nursing home, she didn't have intractable pain, but I could go down the halls and I could hear people moaning, crying. And aside, a different thing altogether, when you talk about addiction, there was a man in my hometown. He had a back injury, and he was in considerable pain all the time. They couldn't do anything for him. He was a church member, and finally one day he and his son-in-law went out to hunt, and his son-in-law found him under a tree where he'd shot himself, and he'd left a note saying that he hoped that everybody understood, but he couldn't stand the pain anymore.
Thank you very much, Ms. Williams. Are there any questions? Thank you very much for coming. I'm going to skip around just a little bit now. Charlene Bunks. Mrs. Bunks.
Madam Chairwoman and members of the committee, I'd like to thank you for this opportunity to speak with you today regarding Senate Bill 109. I am Charlene Bunce. I'm Director of Hospice Operations at the Wellstar Health System. I'm a registered nurse with over 30 years' experience, the last 10 which have been in end-of-life care in a couple of states. And I'm also a certified hospice and palliative care nurse. And on behalf of Wellstar, I would like to thank both the committee and Senator Utterman for her care and compassion regarding pain management. And as someone who has served on the front lines of end-of-life care, I can tell you that every situation is unique and requires this level of compassion that the Senator has put into State Bill 109. Wellstar supports this effort and the Senator's intent in the bill. And additionally, I would like to leave with the committee and leave copies a comprehensive report card that was done, and I don't know how many of you may be familiar with it, in 2000 and renewed again in 2003 and updated in 2004 that grades each of the states for their public policy regarding pain. And in both in 2000 and 2003, Georgia received the grade of a D+. So therefore, that, and I will leave a copy for the committee. So not only do we know on the front lines that it's a concern, but other states have done more for pain management. And as this becomes an issue and continues to be an issue, I applaud this committee for taking this important topic.
Thank you. Are there any questions for Ms. Bunce? Representative Reinders.
Thank you so much. So if we do this, we're going to get an A?
Maybe. Close. It is actually graded on several different areas.
Thank you for that.
Like that. Are there other questions? Thank you very much for coming.
Thank you.
Dr. Richardson? Dr. Ellen Richardson? Is this Dr. Irola?
Yes.
Together, we're going to have, okay, two of you together. Thank you for coming. From Savannah.
Thank you. Good afternoon. Yes, ma'am. I'm Dr. Ellen Richardson. This is Dr. Kelly Arola. We are both full-time medical directors and hospice and palliative care physicians. We work for Hospice Savannah, and we also work for the Steward Center for Palliative Care. We both want to state on record that we represent a community of end-of-life caregivers in Savannah who do support this Bill 109. We are also here to speak on the next bill. So either now or later to clarify the next bill, we can enlighten the committee as far as the difference between hospice and palliative care, if that would be helpful. If you'd like us to wait until we discuss the next bill, that'll be fine, too.
Why don't you just go ahead and do it right now, just the difference between,
Will that help?
I think so,
Okay.
go ahead.
Okay. All hospice care is palliative. Palliative medicine is a specialty that tends to suffering. It tends to the relief of physical suffering, pain and other symptoms, spiritual suffering, psychological, psychosocial suffering, and it's provided by a team of caregivers from all of these disciplines to give whole patient-centered care. All palliative care is not hospice. Palliative care is a new subspecialty in medicine that has only been grown into the United States in the last 8 to 10 years. It was initiated by several centers in the country, primarily large medical teaching centers, who received funds from the Robert Wood Johnson Foundation to develop these programs and then teaching programs to teach other physicians how to do palliative care. Palliative care, as opposed to hospice, is taking the principles that have been learned over years in hospice care of the relief of suffering and applying those principles to patients who do not necessarily either qualify for the hospice benefit or who do not desire the hospice benefit. For example, people who are still seeking active treatment for a disease that may truly be terminal within a year or 2 years or less, or people who are seeking active treatment even in the face of a very short prognosis, for whatever their personal reasons are. And so what we have done in Savannah, and what as they have done in other parts of the country, is we have taken our specific and very specified training in end-of-life care in hospice and palliative medicine, and we have applied those principles through a consult service in our medical systems so that we can be called upon to go see people as a specialist within the hospital, within the nursing home, or an outpatient clinic to work on symptom management, pain relief, and setting end-of-life care goals. Okay. Are there any questions?
I think, Representative Carter, I think since we brought this up, could you explain, since your bill is very brief, the change on the hospice right now, so while we're talking about it?
Sure, I'll be glad to. Thank you, Madam Chairperson. The bill, House Bill 1008, essentially will do nothing except amend the current Georgia hospice law so that palliative care can be provided to persons with advanced and progressive diseases who have a life expectancy of more than 6 months. As was explained by Dr. Richardson, the definition now, currently hospice care under the Georgia Hospice Law is available only to terminally ill patients, and terminally ill is defined as having a life expectancy of 6 months or less. And what we're trying to do here is simply to extend the benefits beyond that. Now, understand that hospice benefits, the payment of benefits, will not be extended at all. This is simple and straightforward. All we're doing is changing the definition so that those people who have advanced and progressive diseases will be able to have palliative care, will have those services provided by hospice the same way that people who are terminally ill have it now. Those people who have advanced and progressive diseases, that is defined as a medical condition which is irreversible, and it will continue indefinitely, and it will result in the end of life. It may be a year, it may be 2 years, but it currently, as the Georgia law defines hospice care, it is not within 6 months. So we just simply need to redefine the definition of hospice. Again, I reiterate that this does not extend hospice benefits. We've actually had a fiscal note done on this, and the Department of Revenue has found that it will not increase any cost at all. The benefits will not be extended. The only cost that may be incurred is that as we have more patients under hospice care, we may have, because of the number of patients increasing, there may be another need for, or more need, I should say, for surveyors. So there may be another surveyor or two needed in the state, which may increase costs, but that would be the only incidental cost involved.
Questions for Representative Miller?
I guess to Representative Carter, then I'm trying to understand, other than differentiating between less than 6 months, more than 6 months, since we're talking about both bills, I don't understand what your bill accomplishes if it's just a time definition and it doesn't affect cost, quality of care.
Could I clarify that?
Yeah, sure. Either one. I'm just trying to understand, because
the way that what is in statute now is being interpreted is that a hospice provider may not provide palliative care unless the patient has a diagnosis of less than 6 months. So in other words, there's a conundrum. And what they're saying is the people with the most expertise and the most training cannot go do this other service if it falls outside of the definition of hospice care. What we're saying is that palliative care is a distinct service from hospice, although it uses the skills and expertise of hospice, and all we want to do is allow someone from a hospice to go into the community with a palliative care service. The reimbursement and the funding is different.
Help me out, though, to make sure I understand what you're saying. Right now, if I have a life expectancy of more than 6 months, I can't be treated for hospice. Is that
correct.
fair? Okay.
That is correct. According to the Medicare definition.
According to the current Medicare definition.
Yes, sir.
Now, if we pass this law, then I can be treated.
You can have palliative care services provided by someone who also works for a hospice.
Is it
but
through
you
a
still,
hospital then, or is it through the hospice that's providing that care?
Palliative care is being provided in many, many different ways. And it is being set up in different systems in different ways. Some hospitals are creating their own palliative care program. Some people are creating independent palliative care programs, physicians who get an interest in it, and it's sort of a sideline or a subspecialty. In our community, our hospice, which has long been established and is a nonprofit hospice, has determined that this is a community need and wanted to be the front runner in creating the service for people who do not qualify for hospice.
One final thought.
Okay.
I just want to make sure that, are the hospitals, we're sort of talking about who's going to be treating these people at the end of the day, whether it's through a hospital or through hospice. Are the hospitals happy you're doing this? I mean, I just
so
was
far,
curious.
Let me tell you how it works. Say, for example, your primary physician is treating you for a serious medical condition.
Let's say I've got lung cancer.
Right.
Okay.
But you're still getting chemotherapy and radiation.
Right.
And you're having problems with pain and nausea that your private physician cannot get under control. What they want to do is they want to consult me to come and see you and give that expert attention. Plus, what I'm going to bring with me as needed is I'm also going to screen you to see if you're having any psychosocial issues, if you're having discharge issues, if your family is under stress, if you're having spiritual care issues, do I need to pull in a spiritual care provider? Because what palliative care does is look at the whole person.
Okay.
And so we take those same comprehensive ways of looking at the patient that happens in hospice and apply them to you. Now, a year down the road, 8 months down the road, your disease may progress to where you do need hospice services, and then you are still entitled to that. But in the meantime, there's something that can be offered to you. Even if the other thing that precludes people from getting hospice is that they're pursuing aggressive curative treatment. And so palliative care can be applied in that case, whereas hospice cannot.
I understand it. I think what you're doing is good, but I have a hard time believing if I'm going to bring in other people versus the care I'm going to get, it's going to cost somebody some more money down the road. And if people are under Medicaid, Medicare, it's hard for me to believe that we're not talking about a cost element. And I'm not saying that's not good, but I'm saying it's just difficult for me to believe if I'm now bringing you into the equation versus my internist, for example, or lung cancer doctor, that costs have got to increase somewhere along the line when I introduce the third party. Now, I'm not saying that's bad, but it's hard for me to believe there's no cost.
Okay. Can I just address? Sorry. My name is Kelly Errol. I'm also do full-time hospice and palliative medicine. I'm board certified by the Academy of Hospice and Palliative Medicine, which is our sort of academy and governing body. What we're trying to do is, as Mr. Carter said, was simply change the definition. That's simply all we're trying to do. And to put it sort of clearly, I'm an expert in this field. I'm trained. So I work for Hospice Savannah. So your physician calls me up and says, I need a consult. I need you to see my patient. By the definition, because I work for hospice and hospice says I can't see patients with prognosis of 6 months, I can't see you because Georgia law says I work for a hospice. So why can't I see? So he consults with somebody else who doesn't have the expertise. The consult is going to be done, but it's better to go to the people who have the expertise. And right now, the law says that the hospice people cannot do it because of the 6-month rule.
Okay.
I agree with you. I just think that there is going to be a cost.
Right.
Doesn't say
Right.
there's not a cost, really wouldn't be
No. Right now, the reimbursement is the same way any other specialist is reimbursed. Only the physician is reimbursed. What we are trying to do in our community is pull in other ancillary services. Much of it is funded by private donation funding in the community.
Dr. Richardson, if we change the law to where you can go past the 6 months, would you then be able to use the Senate law? And if the people are having, they're 8 months out or they're a year out and the pain is, their current physician is unable to get their pain under control, would you then be able to go and have a consultation with that patient, and the physician, and guide that physician in being able to order increased dosages of medicine to get the pain under control?
Absolutely. Absolutely. And not only that, I would feel greatly comforted in having that law, and so would the physicians who consult me.
Thank you. Representative Reinders.
Thank you so much. I apologize for my ignorance. What disease or what illness would give me the longest lifespan once diagnosed as terminal?
Wow. That's. Can you give me a multiple choice?
No, ma'am, but we've said 8 months and a year. You're not giving.
Most
You've
prognosis.
got a wide window.
Right. Absolutely. And the bottom line where I tell patients that we don't know. Physicians.
What's the longest you've ever seen someone diagnosed before death?
That we thought could have had a prognosis of less than 6 months? Probably 2 years.
So you've never heard of anyone who is diagnosed as terminal that lasted 2 years and a month?
Yes.
Yes.
I'm
What's the longest you've heard?
I'm trying to think of my recent experience in the last 2 years, but
I've had patients who've been told they were terminal, and it ended up that their cancer disappeared, and they weren't in the end. We've had those cases, and they are documented.
Unfortunately, that's not the norm.
Would you say that?
But you would be providing your services. You would be providing the services.
We would be providing services for people who are judged by their own attending physicians that if, based on their best knowledge, training, and experience, that their best expectation is that this patient does not have a long lifespan if their disease followed its natural course in spite of best treatment.
I just want to make sure I understand, Madam Chairwoman, if I may, but we're going from 6 months to potentially infinity.
except that the palliative care is only provided when it's needed. For example, if you were diagnosed with a life-threatening illness and palliative care was called in to help you with the emotional stress of that, the spiritual stress of that, and the pain associated with that diagnosis, but then you found a crackerjack surgeon who did a great surgery, and you found a wonderful oncologist, and you went into remission, and then went back to your normal life, you wouldn't need palliative care for that period of time. On the other hand, 4 years down the road, if it recurred, then that's when you would call on that specialist again.
And finally, talk about your training in the spiritual advising.
My specific training?
Is there a standard that is used for you to be able to be a spiritual advisor in palliative care?
No, I don't do the spiritual care. What we do is do the screening to see if that's an issue, and I do have training through my training in palliative medicine to determine whether or not it's appropriate to bring in like a board-certified chaplain, for example, or the patient's own spiritual care provider.
Representative Reinders?
Thank you.
If I may, I want us to get, we're running short of time.
Sorry.
We have about 3 more people, but I do want to get to Mr., and if the doctors would be available after
Absolutely.
we finished.
One comment on the ad hoc committee for
Yes,
Bill
ma'am.
SB 109. I didn't speak on SB 109. All I wanted to say was, with the Pain Management Ad Hoc Advisory Committee, I highly recommend you include physicians who have some training in hospice and palliative medicine on that ad hoc advisory committee. Thank you.
Thank you very much. And I'd like to call the next person, and I appreciate the committee staying with me on this, Anthony Emanuel, who is with Georgia Hospice and Palliative Care Organization. I wanted to be sure that we got to Mr. Emanuel.
Thank you, Madam Chairperson, and the other members of the committee. I'd like to give you the grassroots view on these issues. And what qualifies me to do that? I serve on the board of directors of my county public health board. I serve on the board of directors of the Georgia Public Health Association. I also serve as the state executive for Georgia Hospice and Palliative Care. Those are just titles. My real claim to fame is that I'm married. My bride is a 20-year-plus hospice employee who has been in the field from the nursing level up to her present position as executive director of Hutchinson Hospice, which is a division of Hutchinson Medical Center in Fort Oglethorpe, Georgia. With that said, let me assure you, what's at issue here is quality of life. Quality of life till we take our last breath. Quality of life to eliminate pain and suffering. GHPCO and its members, and we have some 60-odd individual organizations scattered across the state, fully support both House Bill 1008 and Senate Bill 109. And we appreciate the committee's involvement in it. We just want you to know that from the grassroots level, from the people in the field, from the people who are getting their hands, quote, dirty every day, they fully support these 2 bills.
Do we have any questions of Mr. Emanuel from the committee?
Transfer my earlier question on to Mr.
Okay, thank
Emanuel,
you.
and I knew I could do that.
Representative Kidd.
I'm concerned that is the last bill, 1008? Is 1008 going to alleviate a problem with? I'm thinking about doctors who are in pain management. Is that the same as palliative care? And would this bill give a pain management doctor the ability to give larger doses in the case of advanced pain?
The general answer to that is yes. There are specific answers that there are people present who could deal with that question better than I.
Madam Chair?
Yeah.
Now, she's talking about 1008,
Right.
but I think you're getting confused with 109, right? Because that's the bill that would address increased dosages.
Well,
109.
what I'm saying is a patient is not necessarily in hospice, and has been declared diagnosed as 6 months to live, but could have the type of pain, need the type of pain relief that Mr. Emanuel is talking about, is that going to be covered by 1008? Is what I was concerned about, because there were some problems with the pain management doctor not being able to fax. We could not fax prescriptions. My mother would have to get in a car and try to get to, a place for the prescriptions and that kind of thing. I was wondering if this would alleviate some of that problem.
House Bill 1008 would allow palliative care to be available sooner. And through palliative care, Senate Bill 109 would allow the type of medical administration you're concerned about.
It sounds like it takes care of it.
Representative Graves, would you like to, looking at the bill, would you feel like it would be covered? Or this is something, we're not voting on the bill, and we were looking for this kind of thing that we needed to correct.
Kind of comment based upon the previous lady's comments and this one and all, and Representative Millar's question about expanding scope and cost, and I just kind of a comment more than a question, although a question may come out of it. Today, currently, we understand exactly what hospice is. And you are correct. You can't provide certain services unless you're in hospice care, which becomes 6 months or less. So therefore, the palliative care, which by definition may be the same type pain management included along with other things as in hospice, but it's not covered by certain insurances and services. And I think we need to be careful in looking at all of this by changing the definition, as simply as that may be. And they said very specifically, all we're looking to do is change the definition. When we do that, all of a sudden, these hospice provider groups, which have been limited to hospice care, which is 6 months of life or less, now all of a sudden, from that, and that's a vague definition, it's an opinion, it may go a little longer than that. Now they're starting to go whenever the front end's going to be. It may not be 6 months or less. It may be a year, 2 years or less. And we're opening a huge window. And so we're all of a sudden getting into a lot more than I think we were discussing in just the Senate bill when we're tying all this in. Now back to one of the questions of the Senate bill that we had was dealing with the addiction potential. The two ladies from the hospice and palliative care said, yes, they'd love to have the Senate bill because now they could use that. Well, my earlier statement was that in the 6 months of life or less, addiction's not really an issue. It's quality of life pain management. 2 to 3 years or less, or more, we're bringing that issue to the table now. We're starting to say, yeah, this may really become an issue with addictive and problematic. And so I think we've got to be real careful. Both of these are good measures. But I think if we really get into looking at what we're doing by merging these two, and we're not merging them, but when we look at making one such as the other bill is applicable to it, we're opening a lot more reimbursement, payment, and addictive issues than we thought we were going to be initially, just looking at each bill on its own merit. So I think I was concerned we weren't going to vote on the bills. When I got here today, I thought it was a good proposition and we needed to. But through this discussion, I think there needs to be a lot of step back, second look, and I thank you, Madam Chair, for your wisdom in that.
Okay, thank you. Representative Graves, would you be willing to work with us on that?
I'd love to. And you may want to respond, Doctor. I may be totally wrong, but I just being involved, I know when I get a hospice patient, I know what they're going to have. I know what the issue is. I know it's 6 months or less. I'm not worried about addiction, providing pharmaceuticals to that patient, because I'm worried about quality of life issues. And quality of life is important. I pray I've got another 40 or 50 years and my quality of life is great. But when we starting way on the front end and providing all this extra medical dosing, I think we're kind of opening Pandora's box a little bit.
All right, Representative Reiners.
Thank you, Madam Chairwoman. And briefly, I'd like to thank Representative Graves for doing such a wonderful job with the mind of a pharmacist, for bringing up my point exactly. Nobody wants to deny quality end-of-life, quality care in suffering. But to have it open so far out front, I think we have to be careful. Thank you, Representative Graves.
Are there any other questions for Mr. Emanuel? No other questions? Thank you very much
Thank you, Madam Chair.
that. Molly, we have Molly Herron. We're running a little bit behind, so
I'm going to be brief, Madam Chair and committee members. My name is Molly Herron. I'm Director of Government Relations for the American Cancer Society. And as a cancer organization, we most certainly are concerned with palliative care. And we have reviewed Senate Bill 109 and feel very secure that it's a good piece of legislation and respect the committee's willingness to work if they feel like they should go further and work further with it. We certainly respect that and feel like that you can come up with something that's agreeable and good for the citizens of Georgia. And that's simply my statement that we are very much in favor of palliative care, and it's been long overdue, certainly in our state, and look to your wisdom to make it best it can for our citizens.
Thank you very much. Are there any questions for Ms. Herron? Thank you very much. And, let's see, no, Catherine Ivey. We have one more person after Ms. Ivey.
Thank you, Madam Chair. I'll be quick. I'm Catherine Ivey, and I'm here with two roles, actually, an advocate for the Georgia Council on Aging and an employee of Visiting Nurse Hospice Atlanta. And we'd like to speak in support of Senate Bill 109. Stan, would you like to?
I'm the chairman of Visiting Nurse. I just wanted to join our excellent employee.
Thank you. That's nice coming from the chair, isn't it? We'd like to support Senate Bill 109, and as a member of the Council on Aging, we decided to pull out a card on you and mention to you the fact that a member of our council, Martha Eves, who many of you knew, I had the great pleasure and privilege of being able to be with her during much of the end of her life. And I wanted to let you know that with Martha, we were able to manage her pain. And we were able to do that very successfully. With some individuals who are in hospice facilities or at home hospice, we're not able to do that. And as a member of the Ethics Committee of Hospice Atlanta, I can tell you that one of the patients who actually haunt us are the ones that we have to make decisions about because we can't manage their pain. So we've got to sometimes move them out of a home setting or out of our facility setting, which is home-like, and back into, I'll never forget one case, into an ICU. So this gentleman's pain could be managed in an ICU. Now that didn't serve anyone's best interest. Certainly his family couldn't be with him. He didn't want to die in an ICU, but because of the controversy around the medication that he needed and the dosage he needed, we felt we had to do that. So I would just like to speak in support of this bill. Thank you.
Okay. Do we have any questions, please, for Ms. Ivey or Stan? Thank you very much for coming. And our last person, Wayne Oliver.
Thank you, Madam Chairman. My name is Wayne Oliver, and I represent the Georgia Pharmacy Association. We highly support Senate Bill 109. And to kind of sort of bring to your attention, when we talk about appropriate pain management, sometimes there are end-of-life issues associated with that. But in other instances, we're talking about someone who is absolutely ambulatory. And to give physicians and pharmacists the latitude to be able to properly dose that patient and keep that patient comfortable, and in some instances, certainly in the ambulatory patient, keeping that patient functional and keeping them being productive in a workplace or wherever is vitally important. And the protections that Senate Bill 109 provides both pharmacists, physicians, caregivers, and patients is vitally necessary. I'll be more than delighted to answer any questions that anyone might have.
Are there any questions for Mr. Oliver? The one question I have, I'm sure you'll be glad to work with David and Representative Graves. And Representative Graves, if you could work with the doctors from Savannah and with the bill's author, Representative Carter, to see if there is some movement or some way that we can extend that hospice care to a little longer. I would appreciate that. And what? Okay. Are there any other comments from members of the committee? Okay. Sure. Mike, Representative Chuck.
Yes, Doctor. Could you tell me, in the case of a terminally ill patient, how often y'all review that case? If improvements are being done, I mean.
Are those questions for Dr. Ferrain or Dr. Williams?
Yeah.
The doctors.
But I mean, the palliative to care that is being done, it seems that a review is done on a regular basis to determine the illness and the necessity for the drugs.
Could the doctors
Madam Chairman.
Okay, go ahead. Sorry.
Can we get one of the doctors to
Okay,
answer
could
the
the
question?
doctors come forward? Could you come forward, please? We are going out on the web, and we need to have you up here where we can go on the mic.
Thank you, Madam Chairman.
Thank you very much, Mr. Hall. This is something new for us, to have to be so careful about mics and where we sit and where people give testimony.
No. Thank you. I'm sorry. Our palliative care team meets at least weekly, and we discuss patients almost daily, the patients that are hospitalized, nursing home patients, and also on an as-needed basis as things come up. Sort of in a very similar fashion in the way a hospice interdisciplinary team is required to discuss every patient at a minimum of every 2 weeks. Often it's more often than that. And there is physician review at each review.
So am I correct to assume that if the patient improves and
Right.
the palliative care is no longer necessary,
Then we discharge them from our services.
and then the additional medication will be,
If the patient is still on medication that's managing their symptoms, then that's managed by the patient's attending physician,
And that would be-
internist, oncologist, whoever is assuming the care of the patient.
and that is stopped if it's a pain?
No, it's continuing to be managed by the patient's private physician.
Thank you.
Representative Graves?
One thing on that, you do need to realize that these larger doses of patient that we're talking about doing here, you don't send a month's worth of that larger dose in the home. You're only a very few days to make sure it works, and then you'll send a few more days, and then, so it's, I will say, in the case of a at-home hospice patient, it would be rare for them not to have contact with one of the visiting nurses or someone in their home every 3 days, and probably it's going to be more often than that. That's in the early, when it gets toward the end, they're almost on a daily basis. So it's not like there's a stack of pills sitting over there that anybody can just reach in like M&Ms and take. It's not like that at all. So,
Can I just
to
want,
alleviate that.
I just wanted to add, is I think Ms. or Mrs. Kidd said, majority of our patients don't want to take pain medicine. They see it as a sign of weakness, a sign of their illness. These are seriously ill patients we're dealing with, and they see taking it as bad. But when you can make a patient functional and they can work or they can participate in activities and have a good quality of life with their medicine, it makes a huge difference.
Thank you. Are there other questions?
I'm sorry. That's okay.
Are there other questions? Representative Kidd?
Comment, Sharon, thank you so much, was that the quality of life could have been enhanced 2 years before death to the possibility that the end of life could have been extended out further. But the intense pain and the depression and everything that comes with that, I think, hastened the time of death. And so that was my concern, is that palliative care would actually have taken care of this, is what you're saying, and how does 1080 fit into that, 1008 fit into that?
And thank you very
Representative
much,
Carter.
Madam Chairperson. And that's one thing, I don't want these two bills to get confused here and to get intertwined like that. I think the point that was made, whether it was intentional or unintentional, I think we asked a question, will Senate Bill 109 help you? And you said, obviously, yes. Will it help you if palliative care is extended beyond the 6 months in a hospice setting? But at the same time, that's not what we're trying to do here. No. What we're trying to do is to simply be able to provide these services to patients early on and not have to be limited to the 6-month window. And then the question about whether the finances, the costs were going to increase, hospice benefits will not increase, period. It will not be any more cost to the state or to the federal government or whoever's providing hospice benefits. So if there is a way, and I understand the concerns of the committee, but if there is a way to limit that part that is outside the 6-month window, where Senate Bill 109, if it passes and becomes law, is not applicable in certain cases like that, then certainly I think we're doing a disservice, as you say, if we totally eliminate palliative care in those patients, except if they're within 6 months of death.
And the purpose of the bill, it's only to allow the change of the 6-month definition to keep from restricting a physician trained in hospice and working in hospice to do palliative care. That is what the specific bill is about. It doesn't change the hospice benefit. It doesn't change the hospice definition. It's just that the way it has been set up, that the provider in this state interprets that to mean that if you are in hospice care, you cannot see palliative patients if they have a longer prognosis. It's only specific to palliative care being provided by hospice providers.
I think I will use my position as chairman to have the last question. Since we are 15 minutes over our time and we are now out on the web and there may be another committee coming in right after us. But as we discuss this, and we will talk about these bills, and Representative Kidd, if you would help, if you get this extension, one of your major tools in palliative care is pain control.
Correct.
So some extension of ability to use expanded dosages would certainly be helpful if you are going to extend palliative care beyond the 6 months.
That will never hurt. And the way it will not help us personally because of our own training and how to do this,
right,
as much as it will help those physicians who consult us, because they're the ones who have the fear, because they don't have the experience with the medication, they don't have the specific training, and they have the fear of retribution. And so if that is removed, then once we do the consult, explain how to manage the pain, then we can empower all of the physicians in Georgia to treat pain appropriately.
Right. Doctors, thank you so much for coming, and for the audience and for members of the committee. This is something we are all going to be faced with if we have not already faced it with elderly parents. And so this is a very important subject for our Georgia citizens. Thank you very much. Meeting is adjourned.